Good morning. Welcome to our this morning's edition of Urology 60 Minutes. This is a weekly Grand Rounds offering by the USC Department of Urology and its faculty. This morning we have an exciting program on muscle invasive bladder cancer and its multidisciplinary management in general and specifically during the pandemic. We truly have a world-class star cast that is our faculty today. Professor Colin Dinney is the professor and chairman of the Department of Urology at MD Anderson Hospital. And he is one of the MD Anderson Cancer Center, and he's one of the leaders in the field of urologic oncology with specific focus on bladder cancer. Dr. Rosenberg is the medical oncologist from Memorial Sloan Kettering Cancer Center, and he is also bringing world-class expertise to the field, and the more detailed introductions of these folks will be given by Dr. Hooman Djaladat, who is Associate Professor of Urology at the USC Institute of Urology. And finally, we have Dr. Jason Efstathiou. He is from Harvard, from Mass General Hospital, really the leader in radiation oncology from in this arena of bladder sparing treatments for bladder cancer. So without further ado, I'm going to start off with Dr. Hooman Djaladat, who will introduce the various panelists. Hooman?
Good morning. My name is Hooman Djaladat, and I'm one of the urologic oncologists here at USC. I'm absolutely thrilled to host today's panel discussion with the very world-class faculty that we have today on muscle-invasive bladder cancer. We're going to discuss the specific scenarios in muscle-invasive disease. We're going to address two cases and ask each of our faculty for their opinion and the best practices that they offer now. The first would be a low-risk muscle-invasive disease. As you probably know, a few years ago, MD Anderson came up with the recommendations and risk stratification for muscle-invasive disease. Essentially, patients with muscle-invasive disease, muscle-invasive urothelial carcinoma that had any of these features, i.e., variant histology, lymphovascular invasion, hydronephrosis from the tumor, clinically T3 or clinically node positive features in the pelvic area, either in the radiology or by manual exam. They were classified as high risk, and if none of them was present, they were low risk. And they showed that maybe we don't need really to give neoadjuvant to all muscle-invasive bladder cancers based on this risk stratification. This data was evaluated and reevaluated here at USC, as well as Baylor and other institutes. And we all know that the chance of upstaging in low risk is up to 25–30%, although this chance is much higher in 75–80% for a high-risk group. Although there are some institutes that still do offer neoadjuvant chemotherapy as a standard of care for any muscle-invasive bladder cancer. The second scenario would focus on locally advanced urothelial carcinoma, the patients who are cisplatin ineligible. We all know that in the guidelines is essentially mentioned based on level 1–2 evidence that locally advanced bladder carcinoma would benefit from neoadjuvant chemotherapy. However, in cases that there are cisplatin ineligible, it's a tricky situation, and we really don't know what's the best practices in this group of patients. This all would make it even more complicated during the pandemic era. As we all probably around the world have been confronted with this virus infection in the COVID-19 era, this is obviously an infection. And infection always, in contrast to the cancer, there's a lot of challenges. This is a RNA virus, as we all know, that involves mostly upper and lower respiratory tract, but also can involve any organs. 10–15% of the patients who are involved need hospitalization, 1 to 5% need ICU, and the mortality in different reports has been somewhere between 0.1 to 5 or even higher percentage. So this is a real deal, and especially when we put that in the context of high-risk cancers and the management of them, either with surgery or radiation or chemotherapy or other systemic treatments, it's a true challenge. So we're going to discuss those two scenarios by each of our faculties, pre-COVID era in the standard of care and what do they do in their best practices, and in COVID era. Having said that, we all know that the good news is that the COVID is getting a little bit probably lessened nowadays. However, if it rehappens and the pandemic rehappens, it's nice if we all would be prepared for such a situation. And we all know the opinions of the experts until further data will be out there. So without further ado, I'm gonna introduce our distinguished panel, Dr. Jonathan Rosenberg. Jonathan is the director of GU Medical Oncology in Memorial Sloan Kettering. He is a true leader in the medical oncology field in the management of invasive and metastatic urothelial carcinoma. Dr. Rosenberg is a Harvard graduate, went to Cornell for his residency and did a fellowship in medical oncology at UCSF. Stayed close to us for a couple of years, but then moved back to East Coast. He has been a true leader in the field, and he was the PI for introducing the InVigor 210, which was introducing tislelizumab, one of the first immune checkpoint inhibitors for the management of metastatic urothelial carcinoma. We are really thrilled to have you, Jonathan, today. The next speaker is going to be Jason Efstathiou. Dr. Efstathiou is the co-director of GU Radiation Oncology at Mass General Hospital. He's again another Harvard graduate. He did his Doctor of Philosophy in Oxford University and then moved back to Mass General to do residency in radiation oncology, and has been staying there for the past years. He is a professor and the co-director of GU Radiation Oncology in MGH. Wherever you look at any trial talking about the bladder preservation management in invasive urothelial carcinoma, you would find Jason named there. He has been on the as one of the co-chairs of the NCI in the Bladder Cancer Task Force, and he is a true leader in doing the as a co-PI for the SWOG 1806 trial, which is chemo radiation plus minus tislelizumab in the management of invasive urothelial cancer. Jason, it's an absolute privilege to have you here today as well. And last but not the least is Dr. Colin Dinney. Dr. Dinney is the chairman of the urology at MD Anderson Cancer Center. He is, again, another true leader in the field of urologic oncology. He's a graduate from Manitoba University in Canada, did his residency in Halifax, again in Canada, and moved to Houston to do a fellowship at MD Anderson, stayed there for years. He is an absolute star and one of the role models for a lot of us in urologic oncology. He has been a co-founder of the SEO CTC, involving SEO, SWOG, GU, NCI, I mean, you name it. We are absolutely privileged to have you today, Dr. Dinney. I'm gonna now start my presentations. This is gonna essentially talk about the two cases that we're gonna talk, and then start with Dr. Efstathiou, I'm sorry, Dr. Rosenberg for that. I'm sorry, that's me. Okay, so this is the case, the first case. The history is a 53-year-old gentleman with a recurrent painless gross hematuria. And the past medical is essentially nothing, past surgical essentially nothing for GU surgeries. The social history, he has been a former smoker, 15-pack year, really no other significance in his past medical. Physical exam was really non-contributory. His performance excellent. Blood work essentially good, GFR of 102, and rest of the workups were essentially negative. Tumor markers, PSA normal for his age, and also the usual tumor markers we check at the USC, CA125, CA199, and CA also within normal. Urine cytology was sent for him, which was in favor of transitional finding some urothelial carcinomas in the urine. This is the CT scan. We're going to take a look together. I'm trying to control it so it would not go super fast. You can see the lesion on the left lateral area, really not much around it, no evidence of lymphadenopathy or any evidence for T3 disease. Bimanual exam was also negative. He underwent a transurethral resection of the bladder tumor. It was in favor of invasive urothelial carcinoma, high grade, focally invades musculus purpurea. There were some carcinoma in situ close to it. There was no LVI or any variant histology feature. We're gonna discuss this case with our faculty in two scenarios, in the standard and during pandemic situation. I'm gonna also introduce the second case as well. The history is, again, 80 years old gentleman with a recurrent microhematuria, past medical history, some morbidities, diabetes, BPH, hypertension, some passive surgical was really negative. Social story was a really former smoker, 2-pack day for 65 years, 130-pack year. Physical exam, his ECOG is 1, but what's really important is that he has significant hair loss. And we really had to shout talking to him. It was confirmed in audiometry as well. The blood work was essentially negative with a good GFR, the PSA of 3.3, again, cytology in favor of urothelial carcinoma. Let's take a look at his CT scan together again, this case as well. Kidneys has some cysts, but there's no hydro. Really don't see any minor, small lymph nodes, 5 millimeters or so, starting in the pelvic area. But specifically here, you start seeing multifocal tumors and both in the left lateral and anteriorly, which is starting with a clinical T3 disease, some haziness around the bladder. So really radiology-wise, multifocal tumor with some haziness around the bladder, possible T3 disease. He underwent a transurethral resection of the bladder tumor and also close to the bladder neck as well. In favor, the pathology was in favor of urothelial carcinoma, again, high grade, multifocal invasion of lamina purpurea. LVI was there, and there was some involvement of the musculus purpurea. And the prostate chips also, there were some in the specimen that were in favor of high grade urothelial carcinoma, invades the lamina purpurea, close to the bladder neck, and as well as some carcinoma in situ in the prostatic urethra and the prostatic ducts. We're going to discuss these cases as well, and after this discussion, I would show the results and the final pathology or the outcomes of these patients. Without further ado, stop the share. Okay. I'm going to start with Dr. Rosenberg. Dr. Rosenberg, floor is yours.
Thank you very much. There we go. So I'm going to talk today a little bit about our perspective from New York City, which, as I know people have probably heard, has struggled with COVID-19. These are financial relationships that none of which are really relevant to this discussion. So this is a clinical T2 patient with muscle-invasive bladder cancer. He seems to be young and fit. And before March 2020, in our opinion, there are several standards of care that are appropriate in this patient. Certainly neoadjuvant cisplatin-based chemotherapy followed by radical cystectomy with multiple options available. Gemcitabine cisplatin, dose-dense gemcitabine cisplatin, standard MVAC, dose-dense MVAC, or clinical trials. And I'll talk a little bit about some of the data and some of the toxicities that we might think about, particularly around COVID-19. Cystectomy alone is not our first choice, and I know that other centers feel like for the, quote, low risk, unquote, muscle invasive patient that that's an appropriate option. However, I think there are certain factors, particularly in a young patient, where it may think differently. And then for a young patient with a solitary tumor, concurrent chemoradiotherapy is certainly an option, and Dr. Efstathiou, I think, is going to talk about that in much more detail. And certainly we might consider pre-chemo-RT or post-chemo-RT cisplatin-based therapy in a young and fit patient. So there is the temptation of the operating room in a healthy young person with muscle-invasive bladder cancer, the just get it out idea for an upfront radical cystectomy with the hope that everything goes well and it's a low organ confined tumor. But one of the things I think we need to think about is, of course, there are the risk of complications preventing adjuvant therapy if the patient does in fact have high risk features or node positive disease. And in many series, this goes up to 20 or 30% at an MSK in retrospective data. From our series from several years ago at an expert center, the rates of complications preventing postoperative therapy were up to 1/3 of patients, albeit many of them older, but unfortunately it is sometimes unpredictable. In addition, as everyone is probably aware, the data for postoperative chemotherapy for an upstaged patient is less than solid. That multiple adjuvant trials have been conducted, none of which have truly shown a benefit in overall survival. There have been some trends, and there is, and meta-analyses, which are based on flawed trials, have suggested there is an OS advantage. But we really don't have level 1 evidence for the benefit of neoadjuvant therapy the way we do with muscle invasive, with neoadjuvant therapy. We don't have it for adjuvant. So the goal of all of this in treating a young and healthy patient with muscle invasive bladder cancer is to maximize the risk reduction of mortality, death from bladder cancer. And I would generally argue that the biggest risk for mortality in a healthy 53-year-old patient is likely to be their bladder cancer. Yes, they could succumb to an MI. Yes, they could have an unforeseen event in life, but we hope to get another 30 years of life out of this person. And so as we think about a young, healthy patient, there is a lot to lose here. In addition, the data that was referenced before, there is clearly some difference in outcomes in patients who are, quote, low risk, who appear to be organ confined, and who are upstaged with a decrease in cancer-specific mortality of about almost 20%. And in the adjuvant setting, again, there's not a lot of good evidence for adjuvant therapy. In addition, as everybody knows, we're pretty bad at predicting organ confined disease with our current ability to stage patients. And certainly at expert centers, I think, at MD Anderson, at MSK, at USC, and others, we could do a better job, but the average urologist may see 5 or 10 patients a year, may not be as astute in some of the subtleties. And so we generally favor a neoadjuvant approach, even in these low-risk patients, assuming they're young and healthy, particularly if they're young and healthy, in fact. So let's talk about some of the neoadjuvant data. So there are 2 regimens supported by phase 3 data. Classical MVAC has been the standard that which things are judged against, but it has not really been used extensively in many years due to high rates of toxicities, including neutropenic sepsis. although the original MVAC studies were done in the era when we didn't have growth factors. CMV was also tested as preoperative or pre-radiotherapy treatment, and that also showed a modest survival advantage. And then we have data for gemcitabine and cisplatin and dose-dense MVAC, as well as dose-dense gemcitabine and cisplatin. These regimens have varying degrees of downstaging and pathologic complete responses, with the dose-dense regimens seemingly having somewhat higher rates of downstaging and pathologic complete responses. Although, as we get into some of the more recent data, it is a little more cloudy. So Tom Flagg presented comparative data from the Coxon neoadjuvant study. If you remember, this study was in patients with higher risk muscle invasive bladder cancer and compared GC versus dose-dense MVAC. This was not a study to compare the regimens. It was a study to evaluate the co-expression Coxon biomarker to predict outcomes with chemotherapy. But we got at least some estimates of outcomes with neoadjuvant therapy. And I would say, based on this trial, they don't look dramatically different. There was a somewhat higher downstaging rate in patients who received dose-dense MVAC, and a slightly higher or at least similar rate of PT0 with gemcitabine and cisplatin. And so, these are the numbers of patients are not sufficient to draw any conclusions, and it really is meant to be hypothesis generating and provocative. At GU Cancer Symposium this past year, we saw data on the French VESPER trial. And this was a trial of 4 cycles of gemcitabine and cisplatin, or 6 cycles of dose-dense MVAC given in the perioperative setting. And the vast majority of patients got neoadjuvant therapy. And of the patients who got neoadjuvant therapy, the pathologic outcomes favored dose-dense MVAC. However, when we look at the numbers of cycles and the doses of the chemotherapy, we're sort of comparing, at least to some degree, more chemotherapy versus a bit less chemotherapy. 6 cycles of cisplatin versus 4 cycles of cisplatin. And it's difficult, I think, as a result, to completely conclude that the regimens are slightly different. Although in their study, they did have a significant improvement in pathologic outcomes. The studies, this is a secondary endpoint. The final outcome is overall survival. And clearly, if the MVAC regimen wins, then we will need to be thinking about changing our care. But I think for young, healthy patients, in dose-dense MVAC is a perfectly appropriate regimen. And for many other patients, dose-dense MVAC may render them ineligible for a cystectomy or delay it substantially. And so perhaps GC is better in those patients. And so I think they're both good options, and we really have to tailor the care to the patient itself. So febrile neutropenia, higher rates in dose-dense regimens, and certainly gives us pause during this during the pandemic, and so this is something that we've thought about quite seriously. So just to talk about COVID-19 in New York, so the surge hit New York hospitals in mid to late March, and was the worst in the outer boroughs initially. Manhattan was not spared, but didn't fare quite as badly as Queens, Staten Island, Brooklyn, and the Bronx. We see that the surge of cases, which are in orange, peaked around the beginning of April. But in Nassau County, an adjacent county where we have a center, the peak of diagnoses was mid-April, and actually continuing now to go up again. And if you look at the numbers, this is 10,000, this is 1,500. So the suburbs are getting pummeled by COVID-19. Suffolk County looks very similar. Westchester, northern New Jersey, our entire catchment area has been essentially immobilized by COVID-19. The safety net hospitals were the hardest hit, often the least prepared, and the most poorly resourced, unfortunately. The larger hospital networks in New York City were able to shift resources and move patients around, and were able to cope a little bit better. There was a large shortage of personal protective equipment everywhere at all hospitals, and including at MSK. Because we don't have an open emergency room, the medicine services were not quite as badly affected as some of the other hospitals were. And so we accepted any cancer patient from any hospital regardless of COVID status, to help relieve the pressure at other institutions. And in addition, we donated staff to other hospitals, including our academic collaborators, Cornell and Columbia, Mount Sinai, and Northwell. In addition, the GU Medical Oncology Service became a COVID-only service for 2 weeks, and our doctors became COVID experts very quickly, and our GU patients were distributed to other solid tumor services on the inpatient side. Fortunately, the hospital census has gone down, and we've been able to reconstitute a GU service. We had our hospital divided into COVID and non-COVID floors. We doubled the size of our ICU effectively, converting a floor of the hospital to an intensive care unit. And we shifted about 90% of our outpatient staff, really that's both physicians and other staff, to remote work. And we made a dramatic transition to telemedicine, with less than 2% of cases being telemedicine in February to greater than 75% in April for GU Medical Oncology. In addition, as Colin just showed, there was a dramatic reduction in the demand for new patient consults. And actually, that's not yet quite started to rebound in New York at this point. So COVID-19 and cancer treatment with systemic therapy, at the moment, there's very little data, except for the suggestion that neutropenia may be a risk factor for adverse outcomes with COVID-19. There are multiple series that are coming out suggesting that the higher death rate from COVID-19 in cancer patients may be driven mostly by lung cancer patients and liquid tumor patients. There is a Montefiore series that was published with a 15% death rate among COVID-19 GU patients, although it's not clear whether these are inpatients or outpatients. And lung cancer and stage 4 cancer were the highest risk of death. In the coming weeks to months, we're going to be putting forth a series of MSK's COVID-19 inpatient and outpatient cadre, which hopefully will give detailed data on outcomes of our patients. What is most concerning for us, and I think everyone, is the reduced referral for cancer care, reduced diagnosis, delays in care, and patients who might be curable becoming incurable. And some data suggest a possible 20% increase in cancer mortality in affected areas due to delayed diagnosis and treatment of early stage cancers, which is a very discouraging thing. So in this patient in March 2020, our operating room was closed. There was no option for radical cystectomy for more than 6 weeks. And so we agreed that we would prioritize someone like this for a neoadjuvant approach if they're eligible for cisplatin, and we picked gemcitabine and cisplatin as the regimen of choice, as it has a relatively low risk of neutropenic infection, with liberal use of growth factors to ensure that patients don't develop complications and needing to be hospitalized, and we deprioritize the dose-dense regimens with rare exceptions. And chemoradiation is obviously an option for this patient, but one thing that we worried about was the daily treatment for an extended period of time might put the patient at risk for contracting coronavirus, despite all the efforts that we might undertake. Fortunately, as of May 1st, the operating rooms reopened due to the reduced COVID-19 census at MSK and the ability of our hospital to deal with postoperative care without compromising the needs of the coronavirus patients. So to talk briefly about the cisplatin ineligible elderly patient, so these are the criteria for cisplatin ineligibility: reduced GFR, poor performance status, functionally relevant neuropathy or hearing loss, and heart failure that's clinically significant. In some patients, hearing loss can be a soft call, but in a patient with dense hearing loss or requiring hearing aids, generally that's a very good sign, even without an audiogram, that cisplatin is unwise. There isn't a precise age cutoff for cisplatin. The tolerability is less in octogenarians, and it risks making a patient into a medically inoperable patient. In addition, in elderly patients, we need to be thinking about competing risks for mortality when we're thinking about systemic therapies in these patients. So in this case, as probably was discussed, the multifocal disease carries a risk of treatment failure with chemoradiation, but it will also have a lot higher risk of failure with radical cystectomy, and they appear to be an adequate cystectomy candidate. We generally have not used the non-cisplatin regimens as neoadjuvant therapy, as it's not clear that they improve survival. The patient might be a good candidate for immunotherapy trials, but the requirement of a patient to have high-dose corticosteroids if they get autoimmune toxicities appears to be a risk factor also potentially for poor outcomes with COVID-19. And so we have been somewhat reluctant to pursue doublet immunotherapy. We have a trial of ipilimumab and nivolumab available, which we're not accruing to currently. So if there's no OR, consider chemoradiation versus waiting. It depends on how long you wait. And the only concern I would have with chemoradiation is the chance of COVID-19 infection in a highly prevalent environment, such as New York, where the rates of asymptomatic transmission are quite high. MSK has tested probably 10,000 patients and staff, and approximately 20% of them, including many asymptomatic people, have been positive for COVID-19. And in New York, the prevalence of COVID-19 asymptomatic transmission is quite high. And so prior to any surgical procedure, interventional procedure, they're tested for COVID-19 in a very similar fashion. Hypofractionation for chemoradiation would be wise under the circumstances, as Dr. Efstathiou said. So I'd like to thank everybody very much, and hopefully we will eventually all be able to resume normal operations and treat cancer to the best of our abilities, the best way possible, without having to worry about COVID-19. And thank you for putting up with my technical problems.
Absolutely. Thank you so much, Dr. Rosenberg. It was a terrific presentation. We move to Dr. Efstathiou about his perspective on the bladder preservation treatment in these two scenarios. Thank you so much, Dr. Efstathiou.
Sure. Can you hear me okay?
Yep, yes. Everything is good.
Okay, great. So a real pleasure to join this USC Zoom series, a wonderful panel. I'm going to be addressing considerations for trimodality therapy in lower risk patients, such as the patient in case 1. And I'm going to make a, there we go. These are disclosures, none relevant to this talk today. I'm going to make about 7 quick points, and I'll keep these points short, and then at the end address some considerations during pandemic era as well. The first point is that there really has been a paradigm shift in contemporary oncology towards organ preservation. I'm listing a few cancers here where it has become standard. And while many patients certainly do very well with a cystectomy, it is a physiologically demanding operation for a patient to go through, and it can be life-altering. So consideration of bladder preservation should at least be made for the right patients. Number 2, the morbidity of radical cystectomy is well documented by many centers. I'm just presenting some of Sloan Kettering, very, very honest reporting of complications, and this, of course, is at a very high volume center. It's really important for all the urologists here to realize that trimodality therapy very much is a surgical approach. The urologist in the U here is very much the quarterback. A maximal TURBT is needed, cystoscopic assessment of treatment response, long-term cystoscopic surveillance, lifelong, and salvage cystectomy in about 10 to 15% of patients who may require it following chemoradiation. You know, we would argue, and we've published, and the RTOG and RG Oncology have published long-term results of many patients who've gone through trimodality therapy. And we would argue that such results are good and can be comparable to radical cystectomy in the right patients. So for example, here in our series that goes back to the 1980s, you can see very favorable long-term disease-specific survival. If we specifically look at our results in the modern era since 2005, the 5-year disease-specific survival rate is about 84%. And the need for a salvage cystectomy, as you can see here, has been dropping very dramatically and currently is in about the 10 to 15% range. Patient selection for this form of treatment is critical. Here you'll see the factors associated with outcomes. They include T-stage, whether or not a complete response was achieved, lack of hydronephrosis and lack of CIS are good things in terms of outcomes, and the ability to achieve a visibly complete maximal transurethral resection is also associated with more favorable outcomes. So patient selection is important for sure, and those that are most likely to do well, the highest success rates are those with solitary T2 or T3 tumors, usually less than 6 centimeters, no hydro, having had a visibly complete TUR, no extensive CIS, adequate renal function for different chemotherapy regimens, and most of the data is with urothelial carcinoma histology. Though we believe mixed histologies, for example, urothelial carcinoma with squamous differentiation is probably fine as well. There are a number of population-based studies that have tried to compare cystectomy to trimodality therapy. I'm highlighting one here suggesting that cystectomy is better, but these types of studies are fraught with all kinds of issues surrounding confounding, misclassification, selection bias. I've listed a few of the considerations here at the bottom of this slide, but not really to get into it much. There are other large database studies. There's, for example, a recent study from the Veteran Affairs data suggesting that trimodality therapy and radical cystectomy were actually quite comparable if you were looking at patients who got proper trimodal therapy with radiosensitizing chemotherapy, etc. The best data comparing these treatments probably comes from Toronto, where in their multidisciplinary clinic, they've prospectively followed patients and done propensity score matching for those that had cystectomy versus trimodal therapy. And as you can see, as they published in JCO, there was no difference in terms of overall or disease-specific survival in those cohorts. Another consideration, I think, for a patient is regarding toxicity and long-term quality of life. And in general, after bladder preservation, it's good. I'm showing here some long-term quality of life data in a study that we did at MGH with the University of North Carolina. And in general, one point that comes out consistently is better sexual quality of life with chemoradiation compared to cystectomy. That comes through in just about every quality of life study that's looked at that. In our study, there was also a sense of better informed decision-making, less concerns about appearance, less life interference from cancer or cancer treatment. So quality of life discussions certainly need to enter into the counseling of the patient. So some have argued the best bladder you'll ever have is the one you were born with, even if it's had an aggressive TUR and some radiation. It's very important to know that superficial recurrences can occur after chemoradiation. About 25% of patients will develop non-muscle invasive recurrences after trimodality therapy. In general, those can be managed as you would manage de novo non-muscle invasive tumors with TURBT and intravesical therapy, with overall acceptable tolerability, toxicity, and outcomes compared to non-irradiated patients. Now, the one big thing with this patient in case 1 is that he had CIS. And my question for Hooman and others are, what was the extent? Was that just tumor-associated CIS? Was it diffuse CIS? Was it extensive CIS? Because I think that plays into this, because the existence of CIS up front does portend a higher risk for non-muscle invasive recurrences following chemoradiation in the future. Here's some data where we've looked at toxicities following a salvage cystectomy following chemoradiation, comparing them to primary cystectomies from Memorial Sloan Kettering, both using the Clavian grading system, suggesting reasonably comparable results, meaning that a salvage radical cystectomy is feasible after chemoradiation and morbidity is overall acceptable. Again, 10 to 15% of patients may require that salvage cystectomy. And in those that have had a recurrence and needed a salvage cystectomy, look at this, the 5 and 10 year survival rates for recurrent disease like that are still over 50%, which are quite favorable. And coming towards the end here, it's important to know that trimodality therapy is supported by numerous guidelines and advocacy groups. So here I'm listing this for stage 2, clinical T2 and 0, similar to this patient. Indeed, concurrent chemoradiation is a category 1 recommendation, along with neoadjuvant chemo and cystectomy, and therefore I would argue it at least needs to be discussed with the patient in a multidisciplinary fashion. So to wrap this up, basically in 2020, patients should be offered trimodality therapy. The results seem comparable to radical cystectomy in well-selected patients. 85% of patients are going to keep their own bladder with similar rates of 5-year DSS, and long-term quality of life appears to be good. Very important for urologists to realize this is not a non-surgical treatment approach. A maximal TUR and salvage cystectomy are critical components to the success of this paradigm. This is being offered by numerous and supported by numerous guidelines. We've got to have these patients see all three disciplines in counseling of their considerations. And then specific considerations for this patient and during the pandemic era are the following. One, what was the extent of that CIS initially? If it was just a little bit of tumor-associated CIS, I would argue the patient remains a candidate for trimodality therapy. If it was extensive and diffuse, I would lean towards cystectomy as primary local management. Secondly, of course, what's the role for neoadjuvant chemotherapy prior to chemoradiation? That's a big topic, not very strong data, but some data that could support that. So that's a consideration. And here is one thing that we have done at our center during the COVID pandemic time, which is the utilization of hypofractionated radiation, meaning shorter courses of radiation. And there is good data supporting, primarily from the UK, 55 gray and 20 fractions, as opposed to the more normal conventional fractionation, which is usually 32 to 36 fractions, going to mid 60 gray. So you can shave off 2 to 3 weeks off of a patient's treatment course. And that has been shown to be non-inferior in terms of invasive local regional control, overall survival, and late toxicity. And so that certainly would be one consideration during this time. These patients still need treatment, and our department has remained fully operational throughout the COVID pandemic, even though Boston's been pretty hard hit. So I wouldn't want to delay starts necessarily unless the patient's getting neoadjuvant chemotherapy or something like that, but I would use compressed courses of hyperfractionated radiation. And with that, I'll stop there.
Dr. Efstathiou, I wonder if you can also present your points of view in the slides regarding the second case as well. So we can wrap up with a discussion with you. And
sure thing. I will pull those up here.
Thank you. And by the way, Dr. Rosenberg is back, so we probably will resume his slides at the end. Thank you.
Okay. You can still hear me fine, right?
Yeah, absolutely. Everything is good.
Okay. So now I'm going to transition to the second case, and that's in locally advanced disease, elderly patient, non-cisplatin candidate. And the one important point for us to all acknowledge is that cystectomy is not being performed in 50% of the patients that have muscle-invasive bladder cancer nationally. So this is data from the National Cancer Database showing that certainly if patients are older and over the age of 70, 50% are not getting a salvage cystectomy. And that gap is not being closed by chemoradiation. So there is a huge unmet need. And I would argue that chemoradiation trimodality therapy can help fill that gap. And I think that this patient is, sort of falls potentially into this category where, nationally speaking, patients like this may not be necessarily getting definitive therapy with intent for cure, because that is still a possibility. Number two, I think it's important to know that trimodality therapy can be considered in more locally advanced disease. Again, I'm showing the MGH experience, but this pertains to large cooperative group experiences as well, that about a third of patients are T3, T4A. Okay, and again, this patient would fall into that category. So you can consider this. There's data supporting it in more advanced T-stage disease. Of course, if you're T3, T4, the black line, your results are not as good as if it were a small T2. But that would also pertain to surgery and radical cystectomy. Of course, those with more advanced T-stage are not going to do as well. Thirdly, and it pertains to this patient who's over the age of 75, is the influence of age. And we've demonstrated that outcomes with trimodality therapy can be equally good in those that are younger versus older. And here I've shown some propensity score matched analyses where the age was stratified by age 75, less than or greater than, suggesting reasonably equivalent outcomes. So this can be considered in more advanced T-stage. It can be considered in the elderly. Certainly, I think in this patient's case, ideally, if they could have full dose neoadjuvant chemotherapy and they were a surgical candidate, I would fully support that approach, just to be very clear. I'm just making the point that if they are not a surgical candidate or are refusing cystectomy, that trimodality therapy can be a very good definitive treatment option for them. It is important to know that the data supporting concurrent chemotherapy with radiation is strong. I'm showing here the BC 2001 trial, which was randomized radiation plus minus concurrent chemo. In this case, the concurrent chemo was 5-FU mitomycin C. And you could see that their primary endpoint of improving local regional disease-free survival was met. So concurrent chemo with radiation is standard of care. There is a very rare patient that I would not give concurrent chemotherapy to. In the elderly and those that are non-cisplatin candidates, there are plenty of options, including, as we're seeing here, 5-FU mitomycin C. Here is another recent trial from RTOG and RG that looked at cis-5-FU versus gemcitabine, basically showing that low-dose gemcitabine was equivalent in terms of avoiding distant met-free survival outcomes compared to the cis-5-FU. And so low-dose gemcitabine is another option. So there's a number of active radiosensitizing drugs that can be considered. I'm listing them here, and you can see plenty of options for non-cisplatin candidates like this patient. So if they're getting radiation and they've had as good as a resection as is feasible, I certainly would add chemotherapy, concurrent low-dose chemotherapy along with the radiation. Again, as I showed you before, trimodality therapy is supported by the NCCN and other guidelines. In this case, for T3, T4A, N0 disease, concurrent chemoradiation remains a category 1 consideration along with cystectomy and neoadjuvant chemo. And so, again, I think a well-supported treatment option. And just to wrap this portion up a little bit, we've been talking a lot about clinical pathologic factors that impact decisions like T-stage, CIS, et cetera. But what about genomic factors? And that kind of brings us to the era of biomarker-driven management of muscle-invasive disease, and molecular biomarkers help guiding even treatment selection. I'm not going to go through this. I'm just showing you that there are selected biomarkers that have been evaluated in bladder preservation therapy. We've recently looked at immune infiltration signatures, and those seem to be associated with improved outcomes following trimodality therapy when they weren't associated with such outcomes following neoadjuvant chemo and radical cystectomy. So there's a lot of work in the biomarker realm that hopefully ultimately one day will help patients select what treatment may be better for them. It's really important for us to consider, and also during the pandemic, what about clinical trials? And we have a trial with SWOG and NRG, phase 3 trial looking at chemoradiation plus minus atezolizumab, immunotherapy. And that might be an option for these patients. In terms of concurrent chemotherapy regimens, 1 of 3 are allowed, 2 of which are non-cisplatin. So the patient would seemingly be eligible for a trial like this to potentially intensify therapy with the addition of atezolizumab. Of course, many clinical trials are not actively enrolling at many centers. At our center, a lot of clinical trial work has been stopped. If it's considered potentially life-saving, it has continued, and in other circumstances, it's continued. But that's a consideration during the pandemic era. Very briefly, in terms of palliation in locally advanced disease, so those patients that aren't going to really get definitive chemoradiation, there are trials like this from the UK that looked at even just 3 fractions of radiation at 21 gray compared to 15 fractions. And they showed that the overall survival was the same. I mean, it wasn't very good, but it was the same. And these are very frail, very advanced patients generally. But the point is that even if that were the case, which I don't get the sense is this patient's case, there can be hypofractionated regimens that are considered. They generally show pretty good symptomatic improvement in terms of urinary symptoms, and those results are pretty favorable even for the 3-fraction regimen. And I'm just showing here a case of, in this case, a patient that had a cystectomy and then a pelvic recurrence, large pelvic recurrence, who received chemoradiation for palliation, and you can see nice shrinkage of that mass. So in summary, I think again, as we saw, many muscle invasive patients are not getting curative treatment. There's an undertreated, underserved population. Specific considerations for this patient are what type of concurrent chemotherapy should they get? It should be a non-cisplatin based version. Again, the consideration of hypofractionated radiation, as we've already discussed, and the consideration of clinical trials and what is feasible during a pandemic time. Ultimately, we need to validate biomarkers and personalized treatment selection for these patients, including neoadjuvant, concurrent, and adjuvant therapies. And most importantly, and as this nice panel highlights, we need multidisciplinary engagement in the treatment decisions that are being made for these patients. And with that, I will wrap that up. Hand it back to you.
Thank you. Thank you so much for such a terrific presentation. I'm gonna switch the gears to Dr. Colin Dinney now. Dr. Dinney, the floor is yours.
Thank you. Can you see my slides?
I can see you, but not your slides yet.
Okay.
I think the share a screen button down there that we talked about.
Okay, now?
Starting, yes.
Okay, perfect, thanks. Well, first I want to thank Indy and Hooman for putting on this session and inviting me to it and helping us all to make the best of a trying situation. So here are my disclosures, again, none of which are relevant to this presentation. So at MD Anderson, we have adopted a risk-based approach to muscle-invasive bladder cancer. We've identified low-risk patients and high-risk patients to help us identify patients for neoadjuvant therapy. The low-risk patients include patients of clinically organ-confined disease, conventional histology, no lymphovascular invasion, no hydronephrosis, and we would expect a favorable outcome with cystectomy alone. The high-risk patients are those patients with clinically extravesical disease, either with a palpable three-dimensional mass or with histological evidence of invasion to the prostatic stroma, a variant histology, lymphovascular invasion, or hydronephrosis, and the cure of cystectomy is less likely. So why did we adopt a risk-based approach? Well, first of all, we wanted to minimize morbidity and cost by avoiding neoadjuvant chemotherapy for those that don't need it. We also want, at the same time, want to take advantage of the neoadjuvant platform to identify likely responders to platinum-based chemotherapy or immunotherapy. And by taking this approach, we're actually eliminating the error of attributing responses to neoadjuvant therapy to the low-risk patients who are actually downstage by their re-TUR. We expect that these actions will improve response rates for those patients who are predicted to be responsive to various therapies and hopefully stimulate the development of new treatments for those patients unlikely to respond. So the first question is really whether or not we can justify the distinction between low risk and high risk disease. So we had a hypothesis. The hypothesis was we could identify a low risk cohort with a disease specific survival comparable to patients with organ confined disease when treated by radical cystectomy alone, and that for those patients that are understaged, we could salvage them with adjuvant chemotherapy. So we identified about 200 patients with low risk disease, 100 with high risk disease, who underwent radical cystectomy without neoadjuvant chemotherapy. And during the same time period, more than 40% of our patients had received neoadjuvant chemotherapy prior to radical cystectomy. So we compared a number of survival metrics between the high risk and low risk, and reasoned that disease-specific survival was the optimal metric because it eliminated the bias associated with comorbidities. And then we actually confirmed our results in a larger independent data set from USC. Now, here are the reasons for patients not receiving, high-risk patients not receiving neoadjuvant chemotherapy at our center: a comorbidity in 40%, physician choice in 30%, patient choice in 11%, and unknown in 20%. So if you look at the outcomes between the low and high-risk patient, we saw a superior disease-specific survival for the low-risk patients compared to the high-risk patients, with a disease-specific survival comparable to that of patients with organ-confined disease, about 80% 5-year disease-specific survival. And this is the data from USC. You can see these curves are superimposable, the same outcome in the USC population, so about an 80% 5-year disease-specific survival for the low-risk patients. And finally, another group from Europe confirmed the results. They showed a higher cancer-specific mortality in the high-risk patients compared to low-risk patients treated by radical cystectomy alone. However, if you look at the pathology, we do find room for improvement. So 27% of the patients that we thought were high risk were actually downstage to having organ-confined disease pathologically with no high-risk features. Now, their disease-specific survival was comparable to those patients that were low risk and remain low risk at cystectomy. So a very, very good outcome for these patients. At the same time, 50% of our low-risk patients were actually upstage to T3 disease or at high-risk features. And you can see they have an intermediate survival, still pretty good, about 75% disease-specific survival at 5 years. And these are the patients that were high-risk clinically that remained high-risk. Now, finally, we wanted to show that we could actually salvage those patients that were understaged with adjuvant chemotherapy. And here's the data. These are the patients who were understaged who underwent adjuvant chemotherapy compared to those that did not. And you can see a significant difference in survival. And again, here you're seeing an 80% 5-year disease-specific survival for those patients who were salvaged with adjuvant chemotherapy. So just to summarize that data, we have identified a low-risk group of patients with a disease-specific survival consistent with that for patients with organ-confined disease. Adjuvant chemotherapy salvaged those patients who are understaged. And we confirmed our classifier in 2 independent data sets. So the first patient that we're talking to would be recommend undergo radical cystectomy at MD Anderson because he is low risk. However, we do realize that we have to try to improve our staging. So we're taking a couple of approaches to improve staging, improving 3D imaging with a 3-Tesla MRI. And like many of us, we're trying to identify metastatic signatures that can help us identify those patients not likely to be cured by radical cystectomy alone. So this is how we managed patients pre-COVID. So patients were all restaged to assess risk. The pathology was reviewed at MD Anderson. Imaging was repeated as necessary. All patients underwent a cystoscopy under anesthesia with a repeat TURBT and an EUA. And the treatment was determined by the restaging. And in 2010, we initiated a multi-bladder cancer clinic for high-risk patients to make it easier for them to see both of us on the same visit. So what happened during COVID-19? Well, for us, it was probably early March to late April. It really had an impact on our clinical practice because we were trying to save beds for patients with COVID. So this reduced new patient visits to about 30% of our capacity. We also rethought routine restaging cystoscopy and biopsy in patients with a confirmed diagnosis of muscle-invasive bladder cancer because we were asked not to use the operating rooms. So we referred new patients for consideration of neoadjuvant chemotherapy regardless of risk. And we scheduled all out of town patients and new patient consults for teleconferencing until June of 2020. And we'll probably going to continue with that anyway. We also reorganized our cystectomy schedule according to the estimated surge in Houston. We never actually did see a surge in Houston. It was more of a wave that's persisted. And we imposed a 14-day quarantine for out-of-state patients prior to radical cystectomy. And then later on, we were able to COVID test the patients going to surgery 1 day prior to surgery, and with the intent of canceling any patient with a positive test. Interesting, none of the patients who were asymptomatic who went for COVID testing pre-op tested positive. So now what about the second patient? The second patient has LVI, looks like it has T3 disease on imaging, and is platinum ineligible. So what will we do for that patient? Well, those patients who are high risk are referred to GU Medical Oncology for consideration of neoadjuvant chemotherapy. In a patient like this who is platinum ineligible, a combination of gemcitabine, paclitaxel, and adriamycin is our first-line neoadjuvant chemotherapy for these patients. This is based upon data presented to us by Arlene Sifkaratki from a study in metastatic patients. If patients are fragile, they'll get upfront pembro with restaging at 6 weeks, and if progressing, we'll switch to GTA. And we also do want to support clinical trials, and I'll just briefly show one of the trials that we've done in this patient population. This is a pre-surgical trial of durvalumab and tremelimumab in patients with high-risk disease ineligible for platinum. The hypothesis was that neoadjuvant anti-CTLA plus anti-PD-L1 would have an acceptable safety profile for these patients who are ineligible for cisplatin-based chemotherapy. Just to show you, these are high-risk patients. 41% of the patients on this trial had a palpable 3-dimensional mass upon EUA. So they were high volume tumors. 30 of 34 patients had a treatment-related adverse event. That's 88%, 14 or 60% had a grade 3 adverse event. There were no grade 4 or 5 adverse events. 30% of the patients developed grade 3 immune-related toxicity. Most common was elevated liver function tests, lipase, and diarrhea. And cystectomy was only delayed beyond 6 weeks. That was the time frame imposed by the trial in only 3 patients. Now, what about the pathological response? At the time of the data cutoff for the data I'm presenting, 24 of the 34 patients had undergone a cystectomy, and 10 patients, or 42%, achieved a pathological complete response. 2 additional patients were downstage to PT1 and 0, so 50% of the patients were downstage to less or equal to PT1 and 0 disease with this combination. We also looked at the pathological response in those patients with a palpable mass. And again, 6 of 13 patients, or 46%, achieved a complete pathological response. 1 patient downstage to PT1 and 0, so 54% downstage to less or equal to PT1 and 0. And in this patient population, this is unlikely to be due to the RETUR based on our previous experience. We also found, though, that 4 of the 24 patients, or 17%, still had extravesical disease, 2 of which had lymph node metastasis, but only a small incidence of lymph node metastasis in this high-risk population. So in summary, the combination was feasible. We didn't see any grade 4 or 5 adverse events. Patients underwent cystectomy with an appropriate time frame. Downstaging was impressive, but it is a small study, and these are only preliminary results, but they are promising. So what changed with for these patients during COVID? I mean, we had similar restrictions as those imposed on the low-risk patients. Again, avoiding restaging cysto and biopsy in platinum-ineligible patients with a confirmed diagnosis of muscle-invasive bladder cancer, and referring to patients to GU medical oncology. So here you can see the impact of COVID only on our OR volume. This is across the division of surgery. You can see, though, the surgical volume was decreased to 40% of normal in COVID, and now we're planning to recover. So now we've just started our recovery phase. The goal here is to resume 80% of our surgical volume by July 2020. And surgery has been identified as an institutional priority for an aggressive recovery. And that's mainly driven by the profits for high-tech and robotic surgery and multidisciplinary care that provides significant downstream revenue. We're opening up our clinics to do patient visits and resuming normal pre-COVID practice patterns. I know I had to hurry through that because time's going on, but I just want to say thank you to everybody and good luck through these trying times. And as you said, I'm from Manitoba, and here I am back in the homeland having a vacation with my wife. Thank you.
I'm going to share my screens, the results of the essentially what we did for this case. So the first case, this belonged actually to December 2012. This was one of my patients all years. We discussed him in multidisciplinary team at that time. Patient was counseled appropriately. He opted for surgery given his low risk status. He received the cystectomy and orthotopic neobladder at that time. And the final pathology was interestingly, again, downstaged which happens in 25–30% of the cases, to PT1 and 0 out of 40 lymph nodes. There were multifocal carcinoma in situ and negative margins, addressing the question that Jason brought up also. This was, and the initial TR was mostly just peri-tumor CIS, and that was extensive. At that time, we also didn't have blue light that we do have nowadays. It's available in a lot of centers to detect better the multifocal CIS in the patients with bladder cancer. The follow-up for this patient, he was doing fine for 4 years, enjoying his new bladder. In 2016, he had a recurrence in the right iliac bone. Biopsy proven, received the chemotherapy, dose and bag at that time, 6 cycles with the radiation. It was fine for another 4 years, and recently had a spot in the lung. And he obviously was a smoker. So we did a biopsy. It's again urothelial carcinoma, recurring 8 years, and he's waiting for systemic therapy, counseling whether we can resume against splatting, given the fact that the last one 4 years ago versus checkpoint inhibitors is functioning, doing fine. Case 2 again was discussed. This patient belonged to last year summer, and discussed in multidisciplinary and patient counseling. And again, he also opted for surgery. Not that he's at USC, that he receives surgery all the time, but he also we didn't have the SOAG 1806, I think, available at that time. He received cystectomy and neobladder, is 81. And the pathology is also interesting. The bladder gained down a stage despite multifocal initial clinically T2 disease to PT1, N0, 39 lymph nodes, all negative. He also, as you remember, had some disease in the prostatic urethra, mostly was CIS. That also confirmed to have still some CIS going into the urethra and the ducts, but the really margins were all negative. Also had some associated prostatic adenocarcinoma that we see up to 35% of these patients, PT2 for the prostate and TIS for the prostatic urethra, and the follow-ups have been fine since then. I want to thank you, all of you, for such a terrific presentations, such a terrific talks, such a terrific panel. We almost are 10 minutes past the due date. I had some small questions, but I'm gonna forego that. Appreciate everybody's input, and have a wonderful day.
So,
Thank you.
I just wanna thank everybody. Really, Colin and Jason and Jeffrey, these are trying times, and for you to take the time, number one, to just do this, and number two, to put in all the effort that you obviously did. These are not just standard talks. I mean, you folks actually sat down and tailored it to the topic of the morning. So we really deeply appreciate it. You are thought leaders in the field, and it's a pleasure to collaborate with you. Here's hoping that this coronavirus-induced delay has not led to too much progression in many of our oncologic patients. This morning, for example, I was supposed to be doing IVC thrombectomy, and just late last night heard that the patient had developed increasing pulmonary mets and a larger liver met. I mean, he had some metastatic disease initially, but I don't know if this 1 month delay has contributed to it. So, these are trying times, and we look forward to joining hands with you and putting some multi-institutional stuff together. But again, be safe, stay healthy. Thank you, Dr. Rosenberg. Thank you, Dr. Dinney. Thank you, Dr. Efstathiou, for joining hands and making this happen. All of us thoroughly enjoyed your comments and your insights. Have a great day.
Thank you.
Bye-bye.